So that's the simplest frame we are doing that. So this is a femur. Femur, how many mechanical, what are the axes of femur? In tibia, there is one mechanical axis and anatomical axis. So most of the fixators goes, ilizarov frame goes 90 degree to that. In orthofix, it follows what axis? Orthofix follows anatomical axis and ilizarov follows the mechanical axis. So we are calculating mainly based on mechanical axis. And you must get maximum span on the bone as possible for stability. So here, depending on the length, we are doing at the lowest level possible of holding is the adductor tubercle level. And the uppermost is, I go even up to the head of femur. But that is not needed in this case. Suppose you have a subtrochanteric non-onion, then I will put my pin into the neck of femur like your DHS. So you don't have to do that here. So we are just thinking that we have a small corticotomy or a supracondylar fracture, something like that here. We have one ring there, and you can have two rings, but very uncomfortable for the patient when you have all ring for the femur. So we'll keep one ring, and the uppermost level of a ring in femur is middle of the thigh. If you keep anything more above it, patient becomes uncomfortable. Lying on the bed is difficult, or you have to go for the original Russian split bed and all for the ring to go down, because they will not be able to lie down well. So the hip will go in for flexion, and there will be a lot of stress on the pins. So the uppermost level is the middle of the thigh. So if you want to go above it, there are some technical modification like steppering are there. So that's a little more advanced way of doing it. So we are doing one at the adductor tubercle level, then the other one is the subtrochanteric level, the uppermost fixation. So the lower we put one ring, upper we are going to keep an arch. Middle one, you can keep a ring below the middle of the thigh. Okay, so you are going to make a ring, the one which I used for the tibia, already the upper two one, that's good enough, one for the adductor tubercle level and above. And you have to keep a arch. Where is the arch? So this is the original Italian arch, and you are going to keep an arch on this, because the arch takes only on one side. The advantage of the arch is you are going to mainly keep only the, we don't use K-wire for the upper femur. The original Russian they use K-wire, so they have a big arch, big femoral arch. Now we are using only this because this can take to 90-90. You can put two pins like this. So if whole area is holes instead of these slots, so with the slot you have to use the unipin and multi-pin clamps that must be there. A special will have a good 90 ring. Okay, now you must know how to connect this arch to the ring so that it have a full round coverage. So for that you have something called oblique supports, or Jude oblique support. So this oblique support actually what happens, it shifts the ray. You can connect it any number of pieces, like this way. Take one more. You can connect it like, it can come to any level. So what happens is, if you connect everything together from the lower ring plus all these things form such a one unit, it must be strongly linked. So the whole thing acts as one ring. On that the whole thing comes, it works like a full strong block. But the thing is, once you are putting this one, you will not be able to distract that area. So this is, no distraction is possible with this. Okay. Usually my habit is I don't like anything which is projecting outside the ring. So what I do is I keep it very close. So I keep anything into the system is okay. So I don't like anything projecting out. It's only for cosmetic reasons. That is only the art of fixation, because I don't want anything projecting this way. So you have some rods which is projecting that way and one this way down there. So all looks very dirty looking. So make a good frame. Practically it has no value. So even if it is projecting there and here, it is no issue with that. And another thing is, though it is not very important, you can see this. The distance between these is more or this is more. Which is more, this one or this one? Same? Now how do you think? So usually they say, you can see these rings are now, this is above and this is below. This, when you look from there, it doesn't look very good. So if you can keep it the same way, this is my preference, practically all are same. So I always like it this way. So these are symmetrical. Appearance wise it looks nice. So it's important that it appearance wise also nice, because everybody criticizes it is unfriendly for everybody, everything for the patient as well as surgeon. So appearance also is important. So try to make it as neat as possible. So there is a strong block. This, and now you just imagine that you are keeping on your own leg and you are going to keep the arch anterolaterally. And you don't want dead laterally, because when you turn externally rotate, that come and hitches. And you want it on anterolateral surface. So you keep somewhere there, and when you look at it, you want some gap like this. It should not be like this, because the thigh is going in a conical shape. You have more muscles there. So there you want a little bit of gap. So that is the way it has to be fixed. Yeah, generally, suppose your issue is very small, like you can keep it like this. Suppose in a very mild flexion deformity knee, you want only a block above it. You can just keep one ring there and an arch this way. But here you have a lot of distance above. So this is not enough, because the full load will come there. So you have to keep further oblique supports. Frame. You can change the position appropriate way so that it comes to the appropriate way you want. It is a little bit off, and you can, if you want to widen it, you can widen like this. If you want to move that way or this way, you can all do that. Once you are stabilized it, you can lock it in that position which you want. And don't keep anything like this way, because this will produce, this will touch the bed and patient will find difficulty. So this part you must be keeping as this way, this way. So they will have more freedom there. So they can rotate it. Okay. So if you do an end-on view, so this must be enough space. If that is not allowing, you can still do a little bit of, and then finally you lock it. Okay, now if you keep it on to the patient's limb, it is like this. So this is a reason, if you keep a 2-hole ranjicube or 3-hole ranjicube, you will come up to here. And you can do a corticotomy or even if it is a fracture, so that way. So we will make a frame now. So this is actually a jig. So that, like a tibia, you made a jig. So this is a jig for the femur. So once this is made, so your job is very simple. You have to make a wire, K-wire, reference wire parallel to the knee joint and fix this one there. Then the rest of the job is easy. And what are the pins which you keep for femur? Usually for the frame to stay on, you pass one horizontal wire. K-wire under CM guidance, pass a horizontal wire and fix it. Then rest of the pins are very easy. You have tried to avoid quadriceps muscles impalement as much as possible. You have entry like posterolateral, you have posteromedial entry. So your whole quadriceps is free. So you have only one posteromedial, distal most posteromedial. So you have no other options of putting any pin on the medial side. And laterally, you have your posterolateral from the supracondylar area up to the trochanteric area. Because that is your posterolateral approach of the femur. The whole area you can put shank screws. And if you put any pin an anterolateral way, so that will impede the quadriceps. But try to avoid it. But you can still put it. Then when you need, you can still put it there. So your posterolateral entry is there. And upper end, you can still do an anterolateral because the quadriceps mainly works distally. So proximally, you can still do it. But more soft tissue means more painful. Stability will be good. So initially they can have a little pain on that till they get good knee movements. So in the femur, the wire formula is very simple. Reference horizontal wire, posterolateral shank screw all along, posterolateral, anteromedial, and upper you have anterolateral. So all shank screws, posteromedial, one posteromedial, one anterolateral. And option in between you can only optional wires, shank screws. I don't use other K-wire anywhere. If the knee joint is stiff, I will try to retain complete K-wires for the distal femur. If the knee is completely stiff, suppose in a supracondylar non-union or a very bad non-union or stiff knee joint, so I use complete K-wires because to get all the benefits of a K-wire. But if the knee is free, I will not put in K-wires there. The reference wire, usually I remove in 6 weeks time to get back the movement. So my fixation will be 3 shank screw for the distal one plus a K-wire. K-wire will out in 6 weeks time. All 3 shank screw will be there. Approximately 4 shank screws. 4 shank screws. Proximal part. On this side 4, this side also 4. 3 shanks plus K-wire. Yes. You can span it. This is one block now. So this is again a ring. This is another ring. So this whole unit acts as a block. Okay? And now should we go through all the things because the rest of the technique is same. Okay. So on the other point on the table is for practical purposes, at the adductor tubercle level, yes, olive ano? ഉണ്ടോ? Yeah. It's outside extra-articular. So that must be just above the level of the adductor tubercle. So the attachment of the collateral ligament is over this. You go above it, there is no synovium. Yes, okay, good. So So beyond the attachment of the collateral wires, yes. Anteroposteriorly, you check the distance. Like, no, you don't see that, no. You make the space, get more space posterior. You have all edema going there. Transfer to air in the middle of it, Yes. But in the pouch, it actually goes above the femur, no. So try to be. So it will be like this. So with the reference wire, you can still do this movement. So this movement will be blocked by putting the next pin. So now you have no way you can move this way. So the horizontal wire will see that in the AP plane it is perfect. In the sagittal plane, you have still the options of shifting it up or down. What usually do it now, the surgeon has to hold it, and passing pin is easy because this is done on a Ranger cube. So that's a jig-like thing, and into the Ranger cube you put the sleeve, so you cannot make any mistake. Option level, no way. That is not there with the system. So we are using Ranger cube. Ranger cube will you can fix only to the holes. There, use a K wire, probe it. Your direction is perfect. Once that is confirmed, you have to make the incision and sleeve, and after putting the drill bit again, you feel that bone, whether you are slipping anteriorly, because you want two cortical holes. So in the huge thigh, you may not be able to find out where exactly you are getting it. You find out the thickness of the bone, and roughly in the center you have to pass it. This is the original design, no? This is the original one. The multiple hole is not available in the market. I make it. Front view and side. Now, this pin should have been a posterolateral this way, because there is no hole there, so we put it directly there. Corticotomy there. But put an olive wire, you can put olive wires, and you can use even cut olives sometimes. So rest you see that you are passing the wire in full knee flexion. So the quadriceps is held in full stretch position. So once you have made already the frame. Once you make the horizontal wire there, this will automatically be like this. So that is why this is a jig. We are mounting on this one, and the lateral angle to the mechanical axis and the femoral condyle line. What is the angle on the lateral side? 87 degrees. So roughly 90 degrees. So when you make it parallel, the frame must be 90 degrees to the mechanical axis. Okay. Depending on your need. If you have a subtrochanteric non-union, you have to go above. Then depending on your problems. If you have mid shaft, then you are going to keep one step ring and an arch. Here is a supracondylar. So that's why we are keeping it somewhere down. So you can still keep one more oblique support and bring it up. But normally you will have a bigger ring. This is a small ring. This is for tibia. Thigh will have a bigger ring. Bigger ring will have a little more. You have to put more of this ring. And try to keep this one also higher up. You can put additional rods here, no? You have to put additional rods. Yeah, connect straightly with the connection plates. This is not enough. This is only temporary holding. So these 2 rods are not enough. You change to 4 rods. Yeah. Minimum 2 rods. So if the more number of these oblique supports, you need at least 2 rods. If you are very thorough with the anatomy, it's good. The other problem is it will impale the quadriceps muscles and patient will cry with pain. And you need the patient to be in the hospital and regular exercises. And in Russia, I think the patient is, once you start the treatment, till removal of the frame, they are in the hospital. Because all the treatment is by the state. But in India, it is not like that. You put the frame and secondary patient will start irritating when is the discharge, sir? When is the discharge? With that wire, you cannot send the patient off. You need very good physiotherapy. Patient will not do the physiotherapy properly. So we are actually avoiding cavities in the thigh to reduce the pain so that it is friendly for the surgeon and friendly for the patient.